How expensive is Incretin, and have you what's your experience with using it?
Okay. Incretin is quite expensive in terms of initial cash out for our patients. However, the effects of weight loss with it encourages some patients to still go on and use it. But it's several thousand pesos per month. So that actually limits its use. I have some patients who go on it. They're very happy with the weight loss, but once they've lost the weight, they prefer to be shifted back to another drug.
Okay.
However, of course, we worry about weight gain, and also because, as I've explained, there are certain pathophysiologic defects that are being corrected. So it's not really just about
that weight loss. Okay. Well, another question is like, how fast do you see the weight gain? Weight loss. Is it in a month or?
It really depends on how nauseous the patient is.
Okay.
With the drug, because that is an effect. That's a side effect that is actually expected. So some of my patients who suffer from the nausea are unable to eat very well, and that leads to the weight loss, which can be seen in a couple of weeks to a month.
Okay.
But there are some who don't
have that nausea, so
it takes
longer time. Okay. Yes. Do you have a question? So we have one question here. My mother just asked me if metformin is harmful to your kidneys. Is this true? Is giving insulin or shifting to monodrug other than metformin better than increasing metformin dose?
That is a very good question because it is a common question. There is a misconception that metformin actually damages the kidney. It is more damaging to the kidney if your diabetes is uncontrolled. Metformin is a good drug to get our blood sugar to goal. However, I think this misconception has been propagated because, for example, if you are a patient with diabetes and your creatinine suddenly goes up, the response of the doctor is to remove the metformin.
Yes.
Because as we all know, metformin is not to be given for an elevated creatinine or creatinine clearance less than 30. However, if it is not explained properly to the patient will think that it is the metformin that caused the kidney problem, and that is why the doctor
removed it.
How about doses? So metformin can be given in doses up to 2,500 milligrams. Some people won't even give until 3,000 milligrams. However, if you give it in combination, it is possible to get as much control with only 2,000 milligrams. So that is actually the rationale for not increasing the maximum dose, but to add combinations so that you can give lower doses.
Are there any other questions? Okay. There's a question here. Hello, what is the dosing of incretin mimetic? The dosing of incretin mimetic?
It will actually depend on which incretin mimetic you are going to use. So because there are different formulations for exenatide, lixisenatide, and the rest.
I hope that answers your question. Oh, there are more questions. How long? Sorry, the questions are not here on my monitor. How long would you give metformin a chance to work before increasing dose or adding another drug or adding insulin? So again, repeat the question. How long would you give metformin a chance to work before increasing the dose or adding another drug or adding insulin?
Okay. So as I was saying, regarding the metformin, you can wait 1 or 2 weeks when you dose adjust your metformin to see what is the effect on the fasting blood sugar. So if you are not at goal for your diabetes, after 1 or 2 weeks on the metformin dose, you can opt to actually increase. Now, what has become helpful for me is when you get the patient, you look at the HbA1c first and see how far off you are from goal. So if, for example, the HbA1c is more than 8, or the fasting blood sugar is more than 160, in my clinical practice, I usually start them off on 2 drugs at once. And then up titrate or down titrate from there. So some people would give, as I said, metformin and then sulfonylurea, and then another oral agent, be it thiazolidinedione or a DPP-4 inhibitor. These are all oral before you give injectables like insulin or GLP-1 receptor agonists. So the lecture today is just to open our minds that there are other ways of doing it, that if cost was not a problem, there is actually some rationale for giving insulin right after metformin or even GLP-1 receptor agonist.
Thank you. I hope that answers your question. Now, another question. Here, based on your experience, how well does compliance do with respect to insulin and insulin with incretin? And what will the patients do if they skip a dose of the drug? Either insulin probably or incretin?
Okay, so first, the correct term is adherence rather than compliance.
Okay, all right.
Okay, so because that is a more patient-friendly term. In any case, we do have people who miss their doses, and there are insulin preparations that are more forgiving of missed doses as compared to some. For example, for basal insulin, if you miss by an hour or two, that is a long-acting insulin, so there is not much effect to be expected. But if you were on a shorter-acting insulin and you miss the dose, that might have an impact. So for example, for prandial insulins, you're supposed to give them before you eat. So if you are delayed and you actually already ate and forgot to give your insulin, that can lead to a rise in your postprandial blood sugar. I have very few patients on both insulin and GLP-1 receptor agonists, as you can imagine, because of the expense. And expense is always something we worry about with our patients because they are out-of-pocket costs for the patient and are not covered usually by medical insurance. We do our best to educate our patients to keep to proper diet so that when they are giving the insulins, they will know what to do. In my clinical practice, I also teach the patients how to adjust their insulin. I trust them enough to do that. If they are able to understand which insulin has an impact on what blood sugar, for example, then they can adjust their doses. For example, if you give a short-acting or a rapid-acting insulin in the morning, it should have an impact on the post-breakfast and the post-lunch. So if they were to have hypoglycemia sometime in the mid-morning before lunch, then they would know that it was the insulin given before breakfast that was probably the cause of this, and they could adjust that.
We have another question. Okay, we have another question. If you start with insulin, what is the dose that you would start with? Another depends.
Oh, it's another depends, but one useful rule of thumb that I heard from a mentor before is the FDS in millimoles can be used as the dose of the insulin. So for example, if you have a FDS of 10 millimoles per liter, and that is actually 180 milligram per deciliter, that might be equal to 10 units of insulin. But then, of course, you need to adjust. A more scientific way is to actually look at the amount of units needed of insulin per kilo. So for basal insulin, so that's the once-a-day insulin, most people would choose 0.2 units per kilo. So if you were a 50-kilo person and you were going to give insulin glargine, for example, that would be 10 units once a day.
Okay. Another question here. Exenatide has had reports of thyroid complications. How significant is it contraindicated in diabetic patients with thyroid disease?
That has not been a significant problem, but of course, we have to screen our patients for any form of thyroid dysfunction. We have to disclose to the patient that such has been reported, and it will be up to the choice of the patient if she will choose to continue with the treatment.
Okay. Another question. For adjusting insulin, some adjust doses every day or every 3 days or every 1 to 2 weeks during follow-up. From your practice, what is your best recommendation?
Okay, in the ideal world, we should be able to have some sort of blood glucose diary transmitted to my clinic, preferably in an Excel file or even graph. But most of the time, what happens is the patients bring their capillary blood glucose diary to me when they visit, and that could be after a month. Okay, so that is why I choose to give them some sort of hydration algorithm, meaning they can up titrate or down titrate their insulin so that when they come back to me, I can just check if they did it correctly. So I give them a rule. For example, for insulin glargine, you can add 1 unit if your fasting blood sugar is more than 140. Anytime it's more than 140, you add 1 unit, and that becomes your dose for the day. If you get hypoglycemia less than 90, you can subtract 2 units. So in their diary, what you would see would be the date, the blood sugar fasting for that day, and then you will see the insulin that was given, and then you will see whether they up titrated or down titrated. Okay, and then when they come back to me, I will look at their decisions and see if they up titrated or down titrated correctly. So that way the insulin dose does not stay static because I was not able to see them.
Okay. Next question is, how would you personally manage your sample case?
That is actually putting me on the spot. Thank you very much for that question. Because of the weight of the patient, I would not consider giving insulin at this point, if possible. I might give a GLP-1 receptor agonist if the patient can afford it. Otherwise, if the patient cannot afford that, we should at least give something that is weight neutral. So you can give, for example, a DPP-4 inhibitor to try to get the patient to goal, together with, of course, our advice to have proper nutrition and exercise.
Okay. Next question. Asking for your opinion, should diabetes blood tests like HbA1c and FBS be covered by PhilHealth?
I am part of the Unite for Diabetes clinical practice guideline where we were able to show this to the Department of Health. HbA1c is not even available in some of our hospitals or centers. But of course, that is the ideal blood test to be done every 3 months to assess diabetes control. What we have done is there is the World Health document that says you can reach an HbA1c of less than 6.5 if you maintain a fasting blood sugar of 6 millimoles per liter and 8 millimoles 2 hours postprandial. So in our patients who cannot afford the HbA1c, then we could just measure FBS and 2-hour postprandial. I will be very happy if PhilHealth will cover the tests.
So just an update. For those in live streaming, we have 9 from the US, 1 in Germany, 1 in France, 1 in two in Sweden, and 7 in the Philippines, and we have 40 attendees or logged on to the GoToWebinar. So next question. Is it good to combine insulin and incretin mimetic if there are signs of microvascular complications like retinopathy in the patient? Would that be a good combination for these patients?
Retinopathy is a complication of diabetes. To my mind, if you want the retinopathy to not worsen, then we should get the blood glucose to control as soon as possible. If in a particular patient that is the way to control the blood sugar, meaning giving the insulin and the incretin mimetic, I don't see why there should be a contraindication.
Okay, there are no more questions. So, in summary, we discussed the advantages of adding insulin early in the treatment. We discussed a bit about the pathophysiologic approach to therapy. And we explained the synergistic effects of combining insulin and incretin mimetics. And I think one note is that we should consider other drugs now, rather than just the usual drugs that we would give as a second line or a second drug to give in patients already on metformin. Okay. Oh, there's another pahabol na question. Will presence or absence of DM retinopathy change your management?
Oh, in terms of the glucose control, or I mean the drugs that you give for diabetes, probably not. But maybe you're referring to for example, using fenofibrate or fibrates, because there is a trial called the field trial that demonstrated a good effect of the use of fenofibrates for those with retinopathy. So that might be the one that's being referred to, but what I usually get is referral from ophthalmologists requesting that please control the blood sugar so as to arrest the progression of proliferative retinopathy. So we should be more aggressive, I guess, in controlling the patients to prevent blindness.
Okay, so thank you for all those who submitted their questions. That was a very engaging session.